Now I witnessed Mr.Thulasiraj, who is the Executive Director of Alliance Aravind Institute of Ophthalmology, to give his presentation. Tulsi is his background is management. He is from the Indian Institute of Management, Calcutta, is alumni of that. And he worked in Berger Paints and Calcutta for 10 years. And he is kind of pioneered in the digital transformation in that company in the 70s at that point of time in Calcutta. One of the first users of computers. And when he came to Aravind, I think he was a person who was instrumental for bringing all the IT technologies right from the beginning and putting in place all the systems and processes. And after nurturing Aravind, he also moved out to take care of this Alliance Aravind Institute, which is really about caring for other organizations, eye care organizations, within India and also outside India, so that we can really achieve the goal of eliminating needless blindness. So over to Tulsi.
So just want to technical check. You can see the slides and hear me well.
Yes, Tulsi. Yeah, you can.
Okay. So thanks, Ravi, for the introduction and for the setting the context. And thank you, Chakrabani sir, and others on this call. We've had the privilege of working with Mr. Chakrabani very closely, and he has helped a lot in what I'm. My talk is not directly about the hospital itself, which Ravi has covered very well. I'm going to be talking about our strategies for achieving our purpose. In some sense, the purpose, even though we state it is eliminating needless blindness, that can only be achieved if we can provide eye care to everyone. So it is all about can we reach everyone to make sure that everyone in need of eye care gets it. And towards that, what has emerged over time are three broad strategies. And this also will kind of answer a question that is asked of us quite often, saying that why aren't you in North India, why aren't you in Western India, why are you only in Tamil Nadu, and so on. So our strategy has been, that is the area that we serve, which is roughly about 100 million people, covering all of Tamil Nadu, Pondicherry, and the bordering districts of Andhra and Kerala. So in that service area, we have our own network of hospitals where we are trying to do both take care of all those who come to us and also reach out to all the communities. So that is a doing part where we're doing things ourselves. And based on what we do, we have a lot of lessons that we have learned, both on the clinical side and on the process and management side. And then since we are doing the highest volume of eye care work in the world as a single group of institutions, we have that benefit of being able to have a lot of both clinical share as well as management insights that we get. So we have a lot of teaching programs, both on the clinical side and for managers. And the third step, which we discovered quite early on, is that we can make quite a lot of impact or improve eye care by mentoring other institutions, having them do better, to adopt best practices and so on. So this has become our broad strategy to achieve scale, doing what you can do, and then you teach others, and they go back and do whatever in whatever setting they are in, and then you amplify their work by mentoring them. So the doing part is almost like planting the seed. So I'm going to be focusing a lot on the scaling and the mentoring part. Some of this was happening quite organically. helped Nepal when they had almost no ophthalmologists. We helped Maldives more. And then as the need and the demand for this increased, we're willing to help. Many people reached out to us, including the World Health Organization. So at one point of time, the Lions International were launching a global program, and they came to us and they said, "Can we do something to support a global initiative?" So we established in 1992, as Ravi said, Lions Aravind Institute Community Ophthalmology. It had the same goal as Aravind of eliminating needless blindness, but then the process that LICO adopted was doing it through mentoring, training, research, and shaping policies to the extent that we can. So broadly, what LICO does is it does a lot of consultancy and capacity building, a lot of training, the clinical training the hospital does. We do a lot of the non-clinical training in management and outreach and so on. Research to get evidence. We also have a unit for, Ravi also showed it, for patient empowerment, patient education, patient feedback, and so on. And then do projects both on our own. And then we also have certain products and services, mostly on the academics, on the IT front. So when it comes to consultancy services, we work quite a lot with existing eye hospitals. I'll show you certain numbers in the next slide. And we also help new hospitals. It's very common for many hospitals to approach us saying that we're planning to start a hospital, can you please guide us? And in some instances, they even request us to set up the whole hospital on a turnkey basis. Now, we have done that for Grameen, for Mohammed Yunus. Then Rahul Gandhi came and approached us. We have set up hospitals in UP. Then we had the Birlas approach us. We have done something in Calcutta, and Sun Pharma came to us. There's something in Gujarat. And currently, there is one still going on in Nigeria from Chandrai, Tulsi Chandrai Foundation. So in all these hospitals, it is almost like our hospital. So we start the building design, we go to that geography, recruit staff, train or more, and then once the building is ready, we send those trained staff along with our team. We put in all our systems, processes, software, everything, and it is run like our hospital. And we have done probably a dozen of these hospitals in several countries. And we also do a lot of program evaluation, and in some instances, we've had the opportunity of working with the governments as well. So the map that you see in the right corner of India map with lots of marks, basically each mark is a hospital that we work with in India. So for many people, this may sound strange, because when you do something very well, you keep it to yourself to give you a certain competitive advantage. But in our case, we really figured that we can achieve a lot more by encouraging competition. So a lot of LICO's work is about creating a healthy competition. And over time, we have worked with more than 329 countries. This includes China as well, to Latin America, Mexico, Guatemala, El Salvador, many countries in this thing, and almost all of Africa and many countries in Asia as well. And this work of mentoring directly, wherein we collect a lot of information before, after, and so on, we are almost able to double their productivity within 12 to 18 months. And we estimate roughly we have added annually, without any significant investment, probably 8 lakh to 10 lakh surgeries in addition to what they were doing. We also had a chance to work with certain governments when they approached us, like Rwanda, Eritrea, and also Government of India. So this work is largely around helping the leadership of the country to think through what is the ideal eye care for their country, and then help development in the plan, and also in some steps of also help them change certain policies which would be not helping these plans to go forward. So we recognize and help them address those as well. These are some of the evaluations that we have done. We have done this in several countries. WHO has asked us to study eye care in Oman. We have done similar work in China, Cambodia, Vietnam, and so on. When it came to training, this is not basic training like MBBS or MS. These are all training for people who are already on the job, already working, to kind of perform their role better with respect to eye care. So we recognize training is required in 3 levels. At the policy level, which would mean we work with the directors of hospitals or people who are in charge of programs at national level or regional level. So today we can say that manager who's in charge of a country or for a region for providing eye care across several countries have been through one of our training programs. And then once you have got this group done, then you need the next level which can execute what these leaders and the policy makers come up with. So we have the next level of training aimed at hospital administrators or managers, project managers, and so on. And then ultimately, you also need people at the ground to be able to do that. For the clinical part, we have the clinical training. On the other side, we have we're kind of being very selective in making the impact where the training is most required. Like for example, equipment maintenance. It is common in almost every hospital. Like half the equipment should be not usable. So we have this instruments maintenance course and also community outreach training. So just on the management training alone, probably 3,000 odd people have come from pretty much across the globe. And of course, being English speaking, we don't have that many candidates coming from Francophone or non-English speaking countries. But still, we get a fair bit of them coming, for example, from Latin America, where they're mostly Spanish speaking. And then we also do a lot of on-site training. Whenever there are large groups of people to be trained in certain focal areas, then we send out a team from here. And we have done this taken in Laos, where it was for the provincial again, you can see in the map, this training also happens pretty much all over the country, including as far as Caribbean. And then we also have adopted almost 20 years back a platform called as Auro Shiksha, which is quite widely used both from within and also from outside users. This is optimized for paramedics training, and for the trainers as well. The other one is IT services, because I think that today the digital technologies helps a lot. And there again, we have a unit which develops a lot of products for Aravind. And because we have benefited a lot from the IT technologies, we have shared them with several other countries as well. And then the other part that comes to in the development process is training material. While there are plenty of material available for doctors, there's almost nothing available for the allied ophthalmic personnel. So we brought out one of the very first series in this, and this has now been translated in multiple Indian languages into Bengali in Bangladesh, and also in Spanish as well. Eye care to everyone can happen only through universal eye health. And then this requires reaching everyone in need of eye care. And number two, taking care of all their eye problems and doing it in a way that it doesn't bankrupt or become financial burden to them. And that is what gave birth to a new way of working that Ravi talked about, because till that point, till recently, or till about 15 years back, the only method that we had for reaching out to everyone was eye camps. This we are doing in very high volume. We continue to do this. But as Ravi mentioned, it reached only less than 7% of those who felt they had an eye problem. So we came up with the concept of putting permanent primary eye care centers, what Ravi called as vision centers, which can do case finding of pretty much all conditions. If not very definitive diagnosis, they can definitely, they may not be able to pinpoint exactly what it is. For that, people can be referred. But over 90% of the cases, the diagnosis is done completely at the vision center itself. I'll just show you a short video as to how this works. This is a local lady who's just walking in, and see, she's walking in alone, all by herself. She registers, pays 20 rupees for the registration, which is good for 3 visits. And this is a 600-700 square foot facility in the local village. So the technician there does a complete eye exam for glasses, also checks for blood pressure, sugar, because those are common. And then the patient would get a detailed diagnostic exam, very much like he or she would get in a hospital. And then all this data is entered into an electronic medical record. Doctor at the other end. And the doctor is, so every patient gets a doctor's consultation when they walk into this remote clinic using technology. So the doctor is now talking to the patient after reviewing the case sheet. So the patient also is getting satisfied, that they're getting an appropriate interaction and diagnosis with the doctor, even though they're still sitting in Madurai. In this case, the patient needed a glasses, so the prescription was sent by the doctor, which got printed out here. And then there's a selection of frames available, and or ready-made reading glasses. So they can try out a few and then pick whatever they like, and then buy it. So for this lady, if this was not there, one, she may not have come all the way to Madurai or to any other place. But here, probably she spent half an hour or 40 minutes, and then the problem got resolved. And we recognize that within 4 or 5 years, these centers were reaching out to almost 100% in need of eye care. And we estimated this to be roughly 1/4 of the population. 25% of the population would be in need of eye care, and then that many patients or more are registered within in about 5 years, and the number kept increasing. So having discovered this process, we set ourselves a goal of, can we catalyze eye care access to 1 billion people? And towards that, we set up a very detailed process for sharing this whole thing, from orienting the leadership, and guiding the people in setting up the centers, as well as mentoring once the centers come up. And then we also packaged everything. What does it take to set up a vision center? This is a floor plan. This is a furniture plan. This is the equipment that you need. What the investment is about 10 lakhs. And then Orolac came forward, and then they also came up with a Vision Center kit. So they just have to place one. I want one kit, which will give completely everything. At one level, it can just be the equipment, or at another level, it can include software, training, and all of that. And simultaneously, we have been also propagating this, sharing this idea with others, with BRAC in Bangladesh. And this particular photo shows the health minister of Bangladesh standing just behind me, and the national director for eye care. And we are signing a memorandum of understanding for setting up vision centers all over Bangladesh. Subsequently, when at the inauguration of the vision centers, the Prime Minister was personally involved, and she reiterated that they would be covering the whole country with vision centers. And now the ministers have changed. The other person in the coat and the blue tie is the current health minister, and he is also now deeply involved in this initiative. And we have now most of Bangladesh through the government. I think by the end of this year or February of next year, there will be 100 vision centers. The other agency called BRAC, they are also aggressively expanding, and we're also working with several other non-government agencies. What I have here is largely government centers, and I think over time, we should be able to achieve our goal. So I'll stop with this. I've taken a little more time than I thought I should. Ravi, on to you.